Thank you again for the opportunity to present. I'm going to try to keep this as simple as possible, but OCD of the knee is a very complex topic. I'm going to first discuss the definition and the etiology of OCD, but spend most of my time on a diagnostic and treatment algorithm and discuss clinical outcomes. Before I get started, it's important to get all the definitions clear. So OCD, as I'm going to speak about it, stands for osteochondritis dissecans, which is different than OCD, osteochondral defect. And it's important to understand that in children, osteochondritis dissecans is a disease of the bone in which, after a while, the overlying cartilage will suffer. It's very different than a traumatic injury where the bone is normal and the cartilage is injured. So it's important to think about this as a bone disease that then can lead to cartilage disease. We very frequently see it in the medial femoral condyle, the lateral aspect of the medial femoral condyle. We'll get into why that is shortly. That's about 2/3 of the cases. And then of the other third of the cases, the vast majority of those are on the lateral femoral condyle, and otherwise they're kind of sporadically spread about the knee. And while a variety of potential etiologies and pathways have been proposed, it's likely a combination of mechanical issues, such as microtrauma, and dysvascularization or biologic issues, so bad blood supply and mechanical overload. But in general, people who speak on this frequently generally still consider it to be an idiopathic phenomenon. This is an early study on OCD looking at core biopsies, thinking that at this time that this would give us the exact reason for OCD, but it was more confusing than it was answering any questions. So 5 of these 11 had repetitive or direct trauma, 2 had poor blood supply, and 4 had an unclear multiple causes. So it's not entirely clear why we get OCD. This is a case that was published looking at a bone bruise that ended up turning into an OCD lesion. So it's possible that a specific instance of trauma to the knee could be a contributing cause. This is another group who looked at MRI thinking that perhaps it was an injury to what's called the secondary physis. So we know that we have the physis that the primary physis is the physis that we think about that contributes to longitudinal bone growth, but there's a secondary physis that's within the epiphysis that grows outwardly, and then it's possible that an injury there can lead to an OCD lesion. This was an interesting study where this group took very young pediatric cadaveric specimens of the knee and put them into a research MRI, so 9.4 Tesla MRI, so not a clinical MRI, and noted that there was a watershed area in the lateral aspect of the medial femoral condyle, which is the area that we most frequently see these OCD lesions. And the other interesting thing to note, and you can see it in the middle image there, is that the blood vessels in the knee, in the human knee, run parallel to the surface of the joint. They don't go perpendicular outward and feed the joint. And so these vessels are relatively friable and and so microtrauma can injure these vessels. They did this similar study in goats and in pigs and noted that the same was true in goats but not in pigs, and goats, interestingly, get osteochondritis dissecans and pigs don't. So this kind of led to the idea of a vascular predisposition. And so on to kind of clinically managing these. For me, OCD diagnosis is made by history and physical exam, certainly, but it's something that we see on MRI. It's important to understand that there's OCD and then there's normal developmental variance, and that typically you can see irregularity in the epiphysis or on the joint surface in children who are very young, so around less than 8 years old. And that I'll show you a couple images in a second. When you get an MRI, they don't appear to be like OCDs. They tend to be in a little bit of a different spot. So it's important to keep that on your differential as well. So here's a 10-year-old with a normal variant. You can see in this middle image the subchondral plate appears totally intact, and that's not true of a similarly aged patient with an OCD lesion. So it's important to look on the MRI and to look at the subchondral bone and to see if that's normal or abnormal, because that'll tell you if it's an OCD or just a developmental variant. And so here's my imaging algorithm when I diagnose a patient with OCD. So typically it's detected on an X-ray, and then I'm getting from that X-ray, let's say it's a right knee, I'm getting an MRI of the right knee, and I'm getting a standing hip to ankle radiograph, and I'm also getting an X-ray of the contralateral knee, and that's very important because studies have shown that almost a third of patients have bilateral disease, and of those, 40% of the patients are asymptomatic. So frequently we'll see an OCD on the other side that the patient didn't even know or complained about. The MRI will help us determine, like Dr. Goyal said, whether this goes to surgery or non-operative. If it's a stable lesion, which I'll discuss in a second, we tend to do non-operative management. I follow this up with another MRI 3 months later, and we can either continue non-operative management or progress to surgery. And it's also important to get a standing radiograph to understand if the weight-bearing axis is going right through the OCD lesion, because that can set you up for failure with non-operative or operative treatment. And so this is the Hefty staging classification. It's in 5 stages, but I think of this kind of in 3 groups. So stage 1 and 2 is stable. Stage 3 and 4 is unstable, but the lesion is in situ. And stage 5 is unstable and it's detached and floating around the knee. And the reason I think of it in these 3 categories is because that's how we base our treatment. So the stable lesions, we start without surgery, crutches, bracing, and avoiding impact sports. And if they fail, they can go on to surgery. The ones that are unstable, we know don't do well without surgery, and so those go right to surgery with drilling and fixation procedure. I'll show you that in a second. And then certainly the ones that have detached and floated off elsewhere in the knee undergo surgery as well, but this tends to be more of a cartilage restoration type procedure. And so what does that look like? So drilling, you can do either transarticular, like this one, or retroarticular from behind, but we use fine wires, drill into the cartilage and bone in order to stimulate vascular inflow into the bone. Again, this is not a microfracture procedure because the cartilage is normal. It's the underlying bone that's abnormal. Fixation plus drilling also addresses the mechanical instability of a lesion. So here there's some resorbable implants that are used to stabilize the lesion, and then we drill around the lesion. And then restoration can be things like osteoarticular autograft or allograft in order to replace an irreparable lesion. So this is a case of osteoarticular autograft transplantation. And so how do these patients do? Non-operative management is somewhat variable. This looked at patients with stable lesions. At 6 months, 67% had no improvement, and at 12 months, 51% had no improvement. And so a large majority of these didn't do well, but I would argue that some of these patients may not have had a stable lesion. You can see in this image they had cysts and linear signal, which probably indicates that it wasn't stable. But they said that predictors of progression to instability was older age, larger lesion size, and cysts behind the lesion. In patients who have the lesion excised, we know that those patients don't do well. They have a much higher rate of osteoarthritis and a higher rate of requiring arthroplasty in the future, and that's because this, again, is not just a cartilage lesion with normal underlying bone. It's abnormal bone, so you end up leaving quite a large crater that doesn't fill in like you would with a normal microfracture type procedure. And then with regard to drilling, the drilling technique, some people do it transarticular, some people do it retroarticular, but they tend to have quite high healing rates, up around 90% using either technique. And so drilling and fixation of unstable lesions have similar healing rates to drilling stable lesions. Alternative techniques are promising for unsalvageable lesions, but there's not really good long-term data to guide this treatment. And it's difficult to assess the literature because a lot of these studies are limited and have a lot of heterogeneity because there's just so many different treatment options that exist. And so there's a multi-center group that is investigating this. And I would also, again, say don't forget to address mechanical alignment. So when we see a lateral femoral condyle OCD, which is atypical, usually it's medial femoral condyle, the 2 things that we also need to look out for are discoid meniscus and valgus of the knee. The discoid meniscus because it's likely overstuffing that part of the joint, and the valgus knee because the mechanical axis is going through that lateral side, and so frequently we see that those concomitant factors. So here's a patient who has a lateral femoral condyle OCD, and here's the standing alignment film showing valgus on both knees, but worse on the right than the left. It was a 10-year-old female who had 7 months of lateral knee pain increasing in frequency. So here are the x-rays. So lateral femoral condyle OCD lesion. Here it is in the initial MRI. So some bone marrow changes, but nothing too significant. So we underwent 3 months of non-operative management. But here you can see in the bottom row are the follow-up MRIs, which show early cyst formation in the back of the lesion, which weren't there initially, and so this was demonstrating progression, likely because there was a valgus knee and increased overload on this compartment. And so for not projecting so well, but for that reason, they underwent a guided growth procedure with a medial hemiepiphyseal adhesis and a drilling of the lesion. So you can see there was transarticular drilling. You can see the lesion there on the top left. And then you can see 2.5 months post-op, improving, 4 months post-op, mechanical alignment improving, 6 months post-op, still slowly continuing to improve. Once they get all the way over, we'll remove the plate. And you can see at the 6-month post-op that there's infill of the lesion that wasn't there before. So doing well, but continuing to correct. Thank you for your time.